Hi everyone, welcome to this presentation on the NHS Health Check. What is it for and can it really deliver? My name's Duddy and I'm a researcher working in the Nuffield Department of Primary Care Health Sciences at the University of Oxford. I'm so sorry that I could not be with you in person in Calgary for this talk. I had to cancel my trip because I've been unwell, so I should also apologise for my croaky voice and any coughs on this recording. Please bear with me. I'd like to begin the presentation by acknowledging that the findings presented today were developed in a project funded by the United Kingdom's National Institute for Health Research, and to note that of course everything included in today's presentation represents the views of myself and the research team, and not the NIHR or the UK Department of Health and Social Care. So a little bit of background in case you're unfamiliar with the NHS Health Checks programme. The NHS Health Check was introduced in 2008. It offers all adults in England a 5-yearly checkup focused on CVD, cardiovascular disease risk factors. All adults aged between 40 and 74 who haven't otherwise been diagnosed with a related condition that would mean that they were regularly monitored anyway are eligible for the health check. And it's primarily delivered in NHS primary care settings, so that is to say usually in general practice, although sometimes in other settings, including community pharmacies or other community locations like libraries or supermarkets. It's a national programme, but it's commissioned and organised at local levels, so by local councils, otherwise known as local authorities in England, so at kind of local government levels. Excuse me. This slide shows the basic theory of how the health check programme is envisioned to work. Essentially, individuals receive a more or less standardised assessment, and then their risk factors are identified and communicated. And as a result of this, people should receive some kind of personal advice to help them address or manage their risks. And that might involve being offered referrals to what are known as lifestyle support services, so things like smoking cessation clinics or weight management services. It could also just involve being given lifestyle advice. And of course, it might also sometimes involve being offered medication, or recommended medication perhaps. And the result is hopefully early identification of risk factors and therefore the potential prevention of later health problems associated with those factors. Our focus in our project was really on the the middle blue and the green bubble here. So we're interested in considering what happens and what doesn't happen to health check attendees after their risk factors have been assessed and they've been told about them. I'm just going to briefly describe the methodology. So we had 2 strands overall. We first conducted a survey of English local authorities. So these are the bodies that are tasked with commissioning the programme in each area of England. We asked them about their own local implementation of the programme, so their local delivery models, and our questions focused on post-health check support and actions. And in parallel, we conducted a realist review of the literature. So this is an interpretivist style of literature review. We used we used textual data extracted from a range of documents to build theories that it could explain what happens at the end of a health check, or what doesn't happen. And throughout both those threads, we had the benefit of support and feedback from really strong public and professional stakeholders. So we had a group of members of the public from across England who were eligible for or had received an NHS Health Check. And we also had access to a group with a broad range of professionals involved in NHS Health Check's national policy, local commissioning and delivery on the ground. And through the input of those groups, we developed our survey questions, and we also sense-checked our developing theories in the review. And over the next few slides, I'm going to run through a selection of some of the study's key findings. So the findings of our survey confirmed what we suspected, which is that there is significant variation in delivery across England, and then that includes in what attendees are offered or can access post-health check. Now, we conducted our survey mid-pandemic at a time when local authorities in England were very busy and focused on the vaccination rollout. So we did only get a 49% overall response rate, but we were pleased to have responses that covered most English regions. In our survey, respondents indicated that there's significant variation in the number of commissioned lifestyle support services that exist in different local areas. So that's the smoking cessation, weight management, and physical activity support groups and so on. there was a wide range of kind of confidence from local authorities that providers made appropriate use of the services that are available in their local area. And we also noted that only a minority of local authorities reported that they requested data or conducted evaluations on those post-check activities or on longer term outcomes. Our realist review included 93 documents. About half of them were published research articles, but we also drew on learning from the extensive grey literature that exists around the NHS Health Check programme. And in particular, that included materials presented at what was the annual Health Checks conference, which was a sort of forum where lots of local authorities and Health Checks providers regularly shared learning, and on local evaluations focused on local implementations of health checks in different locales in England. And as I've already mentioned, our findings were based on our interpretation of the data in those documents, and our aim was to produce little theories that offer causal explanations for, in particular for the variation that we confirmed was there in our survey. So our primary finding is that the NHS Health Check programme means different things to different people. The way the programme is understood and valued by commissioners and providers in particular has an important impact on how it's delivered, and this has big implications for attendee experience and understanding of the programme as well. So at one extreme, the health check is really understood as a de facto screening programme. It's thought of as a clinical case finding tool that can and should be delivered by the NHS in primary care. And really its primary purpose in this vision is early identification of people with moderate to high risk factors for CVD. In some areas, in a minority of areas, there's a different understanding, and the programme is seen much more perhaps through more of a public health lens, but more as a tool or a vehicle to provoke or support behaviour and lifestyle change. And then on top of this, amongst providers, there's a clear split in the literature between providers who are essentially pretty sceptical of the programme and its ability to deliver, and those who do value and engage with it as a scheme. And as you might imagine, there was also a lot of data in the review that demonstrated how these different dimensions of variation in understanding and engagement filter down to affect attendee experience and how they understand the health check. So in particular, whether the check is experienced by attendees as a relevant and valuable opportunity, or whether it feels less relevant or perhaps a mismatch with their own health priorities, and at worst, a tick box exercise focused on just gathering up essential data about them. Our review also identified many prevailing contextual factors that tend to push commissioners and providers towards a leaner delivery model that is really focused on case finding and on the volume of health checks delivered. So this includes, for example, factors related to providers' skills and expertise, and particularly their skills and expertise in supporting behaviour and lifestyle change. But also important, especially now, competing priorities and high workloads. Remembering most health checks are delivered in general practice in England, the sector is under huge pressure at the moment, and so there is a question about whether the health check is seen as a very important activity. Mandatory data collection and reporting is very focused on assessing the numbers of people who have been invited and assessed in a health check, rather than on what happens to them next. And funding models are often the same. They tend to incentivize higher volume delivery. So, for example, they offer payment per check. And that's in a broader context of overall funding for the programme itself and for the follow-on services that might support people afterwards being really squeezed. So we should note that some local areas are outliers, so there are examples out there of quite different delivery models, but there's also a real lack of evidence on how adopting a different kind of way of running the health check affects outcomes. So I wanted to set this for you in a sort of overdiagnosis context. In particular, I want to refer to Wilson and Younger's principles for good screening programs. So the health check isn't officially a screening program, but as we've seen, a lot of our data has suggested that it's treated as one effectively through a lot of the country. And of course, we've highlighted in our survey and in our review this kind of postcode lottery effect, or you might have heard of a zip code lottery, of just that variation in what's available for attendees after their check. And it's very linked to that principle of that you shouldn't screen people for something without a treatment to be available. And what we think we see is that although it's probable that most people at moderate to high risk are offered pharmaceutical treatment, there's much more variation and limited options for people who might want to pursue lifestyle or behaviour change as a kind of first line response to finding out about risk factors. There's also this question of whether the health check programme diverts resources from the sick to the healthy in the name of prevention, and that balance between case finding and treatment and follow-up. In a lot of economic evaluations of the programme, follow-up costs in primary care or associated with services that people might be referred onto are kind of left out of the health check's equation. And for individuals too, there's a sense that the health check diverts attention from the health concerns that they might have to the health concerns that are encapsulated in the check, really the health concerns of the state. It's probably also worth noting at this point that while we were conducting this project, the Department of Health and Social Care in the United Kingdom conducted their own review of the health check, which was published last December around the same time that we were finishing our research. Their review found a lot of positive things to say about the health check, and it ends with some recommendations to expand the programme, both in relation to covering a younger age range of adults, so at the moment it begins at 40, but extending that down, and also in terms of expanding the focus beyond CBD, and to incorporate a range of assessment and screening procedures for other conditions, including mental health, musculoskeletal, and so on. So this is a kind of 10-year vision for the programme. And I think there's a real contrast between those recommendations and our findings, which I think raise really important questions about whether there could be further unintended consequences of this expansion, and particularly the questions around the postcode lottery and what we would really have to offer people after giving them this check. So I'm going to leave you with my contact details. That's my email address in case anyone would like to get in touch. We're hoping that our final report will be published in the NIHR Journals Library later this year, and elsewhere as well. I'm going to leave you with some pictures of the whole project team. So that's myself, and then Vivian, our PPI lead, Erica, Dr. Erica Gadsby, Professor Janet Kurska, and Professor Jeff Wong, who was the PI on this project. Thanks so much for listening, and I hope that I will be with you all in person next time.